Picture this. You've been in a small concrete room for 11 years. Same ceiling, same walls, same fluorescent hum. You know every crack in that ceiling by name at this point. Today is different. Two guards you've never seen before knock on your door at 5:47 a.m. They're polite, professionally polite. The kind of polite that means something is ending. They walk you down a corridor you've never been allowed to walk before. It's cleaner than your block. Quieter. There's a room at the end of it with a padded table that looks disturbingly like a hospital gurney. They ask you to lie down. You do. Someone finds your vein. And then you wait. Oh, hey there. I'm your host. Dead, caffeinated, and today, unusually qualified to discuss this particular topic. Today, we're talking about lethal injection, the most common method of execution in the United States, the one designed to look peaceful, the one that's been called humane by courts and horrific by doctors. By the end of this video, you'll understand exactly what those three drugs do in sequence to a conscious human body, what the science says it feels like, and why some of the most respected anesthesiologists in the world have called it one of the most disturbing medical procedures they've ever studied. Let's get into it. You probably think lethal injection looks like falling asleep. The needle goes in. The person closes their eyes. It's over in seconds. Peaceful, dignified. The humane alternative to the electric chair. That's exactly what it was designed to look like. Here's the thing about lethal injection. The appearance of peace and the reality of peace are not the same thing. And the gap between those two things is where this story lives. The three-drug protocol was designed in 1977 by a medical examiner with no formal pharmacological training in about 45 minutes on a legal pad. That's not a metaphor. That actually happened. Before we dive into it, I want to ask you a simple question. Ready? Which drug in the lethal injection sequence actually causes death? A, the sedative; B, the paralytic; C, the potassium; D. All three together. If you picked D, technically not wrong. But the real answer is C. Potassium chloride is what stops the heart. The first two drugs exist, in theory, to make sure you don't feel it happening. So what exactly is the three-drug lethal injection protocol? It's a sequence. Three drugs, administered intravenously in a specific order. Each one is a standard medical drug, the kind used in hospitals every single day. Together, in this combination, they are used exclusively to end a life. Drug 1, sodium thiopental, or its modern replacement, midazolam, a barbiturate sedative, supposed to render the inmate unconscious before drugs 2 and 3 are administered. Drug 2, pancuronium bromide, a neuromuscular blocking agent. A paralytic, it stops all voluntary and involuntary muscle movement, including breathing, including the ability to show pain on your face, including the ability to scream. Drug 3, potassium chloride, administered directly into the bloodstream in a massive, concentrated dose. It disrupts the electrical signals that keep your heart beating. Cardiac arrest follows within minutes. Here's the mechanism that makes this controversial in every medical journal that has ever covered it. Drug 2, the paralytic, is the problem. If drug 1 doesn't work properly, if the sedation is inadequate, the person on the table is conscious and fully aware for drugs 2 and 3. They cannot move. They cannot speak. They cannot show any outward sign of distress. They look peaceful. They may not be. It's like being submerged in concrete that happens to be on fire, with a face that has been locked into an expression of complete calm. All right. Here's the timeline. The hour before, the last room. You've been in the holding cell adjacent to the execution chamber since the night before. You've had your last meal. You've spoken to whoever you needed to speak to. The chaplain, maybe. Family, if they came. Now it's quiet. The correctional staff assigned to you tonight is not cruel. They're doing a job. They've been trained to be calm, professional, and detached. The professionalism of it, the administrative normalcy of every step, is its own specific kind of surreal. You're walked into the chamber at the designated time. The gurney has arm extensions. It's shaped like a cross, essentially. You lie down on it. Straps go across your chest, your waist, your legs. Your arms are extended and strapped separately. An IV team, in most states, not doctors, because medical ethics boards prohibit physician participation in executions, finds your veins. 2 IV lines are inserted, one primary, one backup, because reliability matters when there's no second chance to do this right. You can see a window to your left or right, a one-way mirror behind which witnesses sit. Family of victims, journalists, your own family if they chose to be there. You cannot see their faces. They can see yours. The warden reads the death warrant. You are asked if you have any last words. Whatever you say or don't say is the last voluntary communication your body will ever make. Drug 1. Sodium thiopentyl/midazolam. The curtain, the first drug enters the IV line. You feel it almost immediately. Sodium thiopentyl, when it works correctly, produces unconsciousness within 30 to 60 seconds. The experience has been described by patients who have received it in surgical contexts as a warm, heavy pressure, spreading from the injection site upward through the arm and into the chest. Then a rapid, almost violent darkening, not like falling asleep gradually, but like a light being switched off mid-sentence. Here's where it gets complicated. Sodium thiopentyl was discontinued in the United States in 2011 when the sole American manufacturer stopped producing it. States scrambled to find alternatives. Many switched to midazolam, a benzodiazepine sedative that is pharmacologically different in one critical way. Midazolam does not reliably produce the deep surgical level unconsciousness that sodium thiopentyl did. Midazolam can produce sedation, a state of reduced consciousness and limited responsiveness, without producing true anesthetic depth. A person sedated with midazolam alone may be incapable of voluntary movement while still being capable of experiencing pain. The American Society of Anesthesiologists, the American Board of Anesthesiology, and multiple peer-reviewed medical journals have stated this on record. In Clayton Lockett's 2014 execution in Oklahoma, one of the most documented botched executions in American history, midazolam was used as the sedative. 43 minutes after the execution began, he was still alive. Witnesses reported him writhing, attempting to rise and speaking. So, is drug 1 working? If it's sodium thiopentyl, administered correctly in an adequate dose, probably yes. If it's midazolam, administered by a non-anesthetist in a dose that varies by state, from a compounding pharmacy whose quality control isn't regulated, the honest answer is sometimes, maybe. We don't always know. That uncertainty is not acceptable in any other medical context in the developed world. It is the legal standard for execution in 27 American states. Drug 2, pancuronium bromide, the mask. This is the drug that anesthesiologists find most disturbing about the protocol. Pancuronium bromide is a neuromuscular blocking agent. It works by blocking acetylcholine receptors at the neuromuscular junction, the connection point between your nerves and your muscles. The result, complete muscle paralysis. Every voluntary muscle in your body stops responding to signals from your brain. Your diaphragm stops. You can no longer breathe on your own. Your facial muscles stop. Your expression locks in place, whatever it was at the moment of maximum drug effect. Your vocal cords stop. You cannot make a sound. This drug has no sedative properties whatsoever. It does not affect your consciousness. It does not reduce pain. It does not alter your awareness of what is happening to you. In a hospital surgical context, pancuronium is only ever administered after a patient has been confirmed to be at a sufficient depth of anesthesia, because if it's given to a conscious person, that person is now fully awake, fully aware, feeling everything, and completely unable to communicate any of it to the people in the room. Here's the cruel irony. Drug 2 was included in the protocol for a practical reason. It stops involuntary muscle spasms that might occur during cardiac arrest, spasms that witnesses might find distressing to observe. In other words, Drug 2 exists in part to make the execution look better for the witnesses, not to make it feel better for the person being executed. If you are conscious at this point, if drug one didn't work, you are now locked in a body you cannot move, watching the ceiling, waiting for what comes next. You cannot tell anyone. No one in that room knows. But what does this actually feel like? This is where it gets personal, and where the science gets genuinely disturbing. Here's what we know about potassium chloride, drug 3, from medical literature, and from the documented experiences of patients who have received high-dose potassium infusions in non-fatal contexts. It burns. Potassium chloride administered rapidly and in high concentration into a peripheral vein causes an intense burning sensation that travels up the arm and into the chest. Medical literature describes it as severe. Patients who have received it accidentally at high concentrations during routine treatment have described it as, and these are clinical quotes paraphrased, among the worst pain they've ever experienced. The cardiac arrest that follows is caused by the potassium ions disrupting the electrochemical gradient that controls your heart's electrical system. Your heart doesn't wind down gently. The cells responsible for coordinating the heartbeat, your sinoatrial node, your Purkinje fibers, receive a signal they cannot interpret and stop firing in any coordinated way. Ventricular fibrillation, cardiac arrest. If you are unconscious, this is the end. You feel nothing. If you are not, if drug 1 produced sedation without true anesthesia, if the IV line was partially compromised, if the dose was miscalculated, then you are conscious, paralyzed, and burning. And you look to every person watching through that window, exactly like someone who is peacefully asleep. Survivors of near-execution experiences, those whose sentences were commuted after the process began, or whose executions were halted, have described the experience of being in the chamber, strapped down, as a specific variety of terror that has no civilian equivalent. The removal of all agency, the administrative finality of each step, the knowledge that the people in this room are following a protocol and the protocol ends with you not existing anymore. The body in that moment understands things the mind is still trying to catch up to. Quick reality check. Since 1976, when the United States reinstated the death penalty, there have been over 1,550 executions. Lethal injection accounts for the overwhelming majority, used in over 1,300 of them. The Death Penalty Information Center has documented 3% of lethal injection executions as botched, a conservative figure that only counts cases where observable problems were reported. The real number, accounting for cases where internal failure would be undetectable, is unknown by definition. Lethal injection is currently legal in 27 U.S. states. Federal executions also use the method. No other developed nation uses lethal injection as a method of capital punishment. Most abolished the death penalty entirely decades ago. The U.S. Supreme Court has ruled multiple times, most recently in Glossip v. Gross in 2015, that lethal injection does not constitute cruel and unusual punishment under the Eighth Amendment. The ruling was 5-4, one vote. This section is a little different. There are no safety tips for lethal injection. You're not going to accidentally encounter potassium chloride on your way home. So instead, here's what to do with what you just learned. First, understand that humane and painless are not synonyms. A procedure can look humane to observers while being experienced very differently by the person undergoing it. Those are two separate things. The distinction matters. Second, if you ever serve on a jury in a capital case, you now know something most jurors don't. The execution method is not the sterile, guaranteed, medically supervised procedure it is often assumed to be. That's information. What you do with it is yours. Third, the medical community's position on this is not ambiguous. The American Medical Association, American Nurses Association, and American Board of Anesthesiology all prohibit their members from participating in executions on ethical grounds. when the people who administer anesthesia for a living refuse to be involved. That's worth knowing. Here's my note from one dead guy who's thought about this a lot. The most unsettling thing about lethal injection isn't the drugs. It's the paperwork, the schedule, the administrative normalcy of every step, the way it has been engineered to look like medicine while being the opposite of medicine. Make of that what you will. So, there you have it. Lethal injection. 3 drugs. Designed in 45 minutes on a legal pad in 1977. Used over 1,300 times since. It may be the most peaceful-looking method of execution ever devised. Whether it's the most peaceful-feeling one is a question that, by design, can never be fully answered. And that might be the most unsettling sentence in this entire video. Like and subscribe if you enjoyed this uncomfortable intersection of law, medicine, and mortality. Drop your suggestions in the comments. Next death might be yours, hopefully not this particular kind, but statistically speaking, you're probably fine. I'll be here. I'm a ghost. I don't have an opinion on capital punishment. I have an opinion on potassium chloride, and it is not positive. Stay curious. Stay uncomfortable. That's where the real education lives.